Well, yeah, I guess we can go ahead and get started now. It's a couple minutes past the start. Thanks so much, everyone, for introducing yourselves. So first off, we have Jessica presenting, Jessica Flannery presenting, breaking down the stereotypes between academia and industry in service of advancing quality care.
Great. And I think I'll be the outlier of not having data that I'm presenting here. So this will be a fun start. So I think it's important to give a bit of my background of why I'm bringing this up here. So I'm the founder of Translational Science, where my background is I'm a licensed clinical psychologist and developmental social neuroscientist. And I've been really heavily rooted in academia, but was really pulled to industry for a couple reasons, including the scalability, and really that ability to apply what I was doing at levels I couldn't otherwise. And so I've been in my consulting roles and working different businesses and consulting for industry as well as academia. I've seen some themes come up of myths both groups, if we put them in groups, have about one another that I've seen really impede progress. And I just wanted to bring those to the forefront of how that can really, if our goal is to innovate and make things better, keeping these siloed or not acknowledging these myths have really come to hinder some progress in different ways. So I won't necessarily read everything, but I think the point I really want to make is for folks that are really academic focused, some of these myths on the left around myths around industry can really keep people out when that could be the perfect fit for applying, doing rigorous work in a different setting. And the myths on the right are really ones that I'm not sure I knew about until it's really an industry that we can come in and think we know a lot, and there's a lot we actually don't know, and that can hold us back. So being aware that industry doesn't see academia as the know-alls either, and there's some things that both sides can work and learn from one another. And they really think of each other as a spectrum that can really feed into this loop instead of these two industry academic paths. So kind of leave it there because I don't want to just read it all, but happy to talk more about it with anyone offline. And if there's time to just hear other things people think they would add to this list on either side of myths that have impeded progress for them in any of their roles.
Thanks. That's super interesting. I guess I can get us started off with just a quick question about like kind of where you gathered these myths from and like um, your reasons for selecting these ones to present on the poster.
Yeah, I think the myths about industry are ones I noticed in my graduate training. I came from a very research heavy training background that was really setting me up for an R1 role. And these are ones I'd heard in and out that these are just, it's a backup, that your integrity is worse, scientific rigor is way worse. And that if I really cared about my subject matter expertise, if I really cared about developmental neuroscience, I couldn't do that anymore. So a lot started there, but then the more I've talked to different people, so I still talk with from my graduate training, my clinical residency, and then where I postdoc, I still talk with quite a few people from there and the people that have gone on to start labs. These are the perpetual themes that are brought up. And recently I was going to maybe go back to academia, was offered a role at a university, a tenure track role. And these were actually brought up from them as well. So I was like, oh, these are still strong and true there. And for me, it was very much not a backup role. I had that option, did not go that route. And then the myths about industry or about academia from industry are ones that I've learned on the job where people are like, oh, we don't want to bring this person in because of X, Y, and Z. I'm like, oh, wow, there's a lot of biases that academia just can't move. They can't scale. They can't do these things. And, they really can. We need both, right? I don't see either as better than by any means. You really got to be thinking about what you want to be doing in that whole spectrum of needs there. Okay. Sure.
Any other questions? We still have a couple minutes for questions.
I'm just going to say, Jessica, I totally agree with all those points. This is helpful to know
Oh,
and,
great.
and for it to be explicitly stated.
Awesome. Thanks. Yeah, curious now or after people think of other ones. I'm always curious to hear other things that people have heard.
People think that moving into industry means that you stop publishing, but like actually, depending on the role that you move into, you could actually have access to way crazier and like more impressive data sets from commercial deployments, be able to write some pretty sick papers as a consequence of it. And just because you left your academic position doesn't mean that you have to stop publishing.
Yeah, definitely. I still publish all the time. That's a really great point. And yeah, on bigger data sets that are more representative, it's pretty cool.
Yeah.
Jessica, I'm curious if you can speak to, so you very well pointed out a lot of the myths that exist on both sides. And I think everyone who is in attendance here is aware of these myths and has an open mind about overcoming these. But how do you think we can systematically start to address these myths and encourage more collaboration?
Yeah, I've been thinking about this a ton and talking to different people about it. One thing that I've been chatting with some different folks that have different levels of say in the matter is, things even down to conflict of interest components on how things are presented. So for example, certain conferences have industry put a conflict of interest up if they want to talk about that they have data, or papers have a conflict of interest. I'm not saying to take that away. They do have a conflict of interest, but so do academics. That is your currency for everything. So sometimes it's just getting people to acknowledge what all the different components are. So there's conversations I've had with folks where they've talked about, implementing things where everyone just discloses, well, this paper helps my grant, this helps promotion, and other components where we kind of just need to keep having this conversation first with the people that are more open and having that kind of spread out. But I think there are some more systematic things we need to do that are keeping it siloed and keeping it separate. So there's another conversation yesterday that I was a part of where we were just talking about how do we just integrate this into just an applied part of training. So it's not seen as industry work, but how do you gain some skills to apply your work or gain some entrepreneurial skills, which can go into industry or being a PI. There's skills that are really highly transferable that we can market within graduate programs that don't make it sound as if you're jumping ship, but learning business skills, which running a lab is your mini business. So I think there's ways and we've framing the skills to not make it sound or feel like someone can't take those classes or courses if they were even offered because they would be seen as going against the regular path. But it's a good question. I think there's tons more that I'm not thinking of right now that I love other people's thoughts on too.
Thanks for all the great questions. And there's one more in the chat. I guess we should probably move on to the next presentation for time, but maybe if you're able to address that via the chat. So next up is Francisco presenting Assessing Predictive Factors of Attitudes Toward Peer-Supported Mental Health Interventions in the Metaverse, a Mixed Methods Study.
Great. So, hi everyone. Let me just make sure this is playing. Great. Awesome. So, kind of thanks so much for showing up and for, kind of listening to my presentation. I really appreciate it. Kind of like I mentioned earlier, I work for the Depression Treatment Lab at USC with Dr. Iony Ezawa. And kind of one of the major veins of research that we're interested in, at least over the last few years, has been digital mental health interventions and sort of just their proliferation in terms of, digital mental health interventions are accessible in terms of they're usually a lot more affordable than, going through insurance, going through a professional, kind of psychotherapy plan. And they're also sort of just a lot more, you can kind of leverage that non-professional helps, for example, from peers, like peer support type stuff, in order to kind of implement these digital mental health interventions at scale, right? Which is something that we kind of need in terms of, kind of this mental health crisis that is getting worse in America and sort of throughout the world in terms of just, not enough resources to meet the need for mental health care. So one of the digital mental health interventions that we've kind of been looking at over the last year or so has been this idea of metaverse mental health interventions. Metaverse, kind of using that in the current iteration to mean kind of just this idea of these 3D social virtual worlds, kind of built off of things like, Second Life, Rec Room, VR chat, right? If you're familiar with any of those, you know that this, or that's kind of similar, at least kind of the way the current iteration of the metaverse, right? And obviously there is sort of the future idea of, kind of a more at scale social interconnected world that, we're kind of just not there quite yet. However, there is kind of this avenue for mental health interventions to be delivered inside the current iteration of the metaverse, where you can kind of use these anonymous avatars to mediate social interaction and mediate the delivery of mental health interventions. However, of course, these metaverse mental health interventions are very new. It's only been, kind of a year or two that they've even really been developed. So little is known about sort of, kind of the populations that would be more interested in using a metaverse mental health intervention, as opposed to sort of a face-to-face intervention or, kind of similar ideas to that, right? So what we kind of wanted to do is just do a simple study, take a look at general participant or general client attitudes towards using a metaverse mental health intervention. So we recruited 545 participants, mostly through Prolific, an online recruitment platform. As you can see, we assessed factors in 4 different major groups: demographics, identity centrality, mental health factors, and technological factors. We use both statistical modeling as well as a qualitative analysis, a content analysis, which was performed on 483 very brief kind of like open-ended responses that we collected from people just to elaborate on their reasons behind intervention preference. So in terms of the results, as you can see, kind of older age, Hispanics, more positive computer attitude, and higher ethnic centrality were associated with greater interest in and preference for MMHIs. To kind of just touch on those, it might seem, a little bit interesting that older age is associated with, more interest in sort of these technologically novel interventions. However, that is something that is sort of reflected in the literature in terms of, people of older age do seem to kind of be more open to trying new kinds of interventions, trying new kinds of, things that might be able to help them out with, whatever mental health issues they may be experiencing. And as you can also see, more negative attitudes towards mental help seeking predicted preference for MMHIs, which is promising with regards to kind of outreach to people that may have more negative attitudes towards traditional face-to-face mental health services, but might kind of this might appeal to them in terms of it's low intensity, it's not as kind of stressful in terms of they have to go somewhere, they have to, other people can see them, can see their face while they explain their issues. So, MMHIs could be something that appeals to people like that. And there's also, kind of just some remaining questions, especially, kind of one thing that we found in the qualitative themes that kept popping up a lot was this idea of, people were a little bit, people kind of had like this sort of fear, apprehension of being, kind of like the way some people phrased it was that it's kind of dystopian to think of like, oh, oh, you're sad, like just put on your headset and then come join everybody else and we can talk about it. Like it's just, some people were very apprehensive of that and just kind of like some really strange or scary associations with that. So there are definitely some, apprehensions in the general population that, I think need to be addressed before this can really be implemented at scale. But, I do think that this is a good start in terms of, identifying what sorts of populations, what sorts of people that MMHIs might be uniquely suited to help, as opposed to kind of, face-to-face interventions or even other kinds of digital mental health interventions that may not be anonymous, may not be as social, et cetera, things of that nature. So yeah, and of course, as you can see, we're currently working on some other projects like a clinical trial testing the efficacy of a novel metaverse mental health intervention. So, we are kind of following that vein of research, and it does seem to hopefully be fruitful in terms of being able to find interventions that we can leverage to kind of implement mental health care at scale in a low intensity way.
Awesome. Thank you so much. Just opening the floor up for questions. got any other?
Uh,
Yeah.
yes, thank you so much for this fascinating work. I'm curious, can you talk a little bit more about how do you select these participants, like prolific, when you determine the demographic? Is there anything like you're trying to determine, or you're like, what are some criteria when you're recruiting these participants?
Yeah, of course. So I would say that, kind of what we started with at first was just a simple Qualtrics survey that we
Hello.
advertised on, various social medias, on Reddit, things of that
Right.
nature. We ended up getting a lot of sort of, bot responses and things of that nature. So that kind of was something that we ran into initially. We were like, oh no, like what's going to happen? Like, we need to throw out a lot of this data. So that was, definitely something concerning that happened at first. So then we switched over, like we said, of course, to Prolific, which is basically just an online website where you can, you basically just pay people a certain amount for them to complete surveys for you. And, it's sort of a bank of people that complete surveys, almost for a living. So they are kind of used to completing surveys. It is sort of a slightly different population than, kind of the general population that isn't completing surveys all the time. So that is something to keep in mind. However, in terms of kind of just recruitment, the only rules we really looked for was that we wanted to have a representative sample. So we kind of split it up into racial lines in the sense that we recruited, I believe it was 100 people that self-identified as white, 100 people that self-identified as Asian or Asian American, 100 people that identified as Black or African American, 100 people that identified as Hispanic, Latino. So we were able to kind of get a diverse sample through Prolific's, recruitment filters, which is, kind of why I recommend Prolific, and I really do like it for survey-based research. However, of course, you do have to keep in mind that, these are people that are completing surveys, probably more than the average person. So, whatever impact that might have on your data is something to keep in mind.
Maybe time for one really quick question, or if not, we can move on to the next one. Okay, well, thank you so much again. Next up is Cassidy presenting leveraging a remote digital assessment to characterize long-term forgetting in cognitively unimpaired older adults.
Thanks, Caroline. Just gonna pull this up. Okay. Awesome. Yeah, so basically accelerated long-term forgetting is the phenomenon whereby individuals have unimpaired recall performance during standard clinic testing with delays of 20 to 30 minutes, but show accelerated forgetting of information after longer intervals of weeks to months. Actually, just gonna zoom in here a little bit because I know it's small. So here we examine the utility of long-term forgetting as a marker of preclinical Alzheimer's disease. In this study, we used a remote digital assessment, namely the Boston Remote Assessment for Neurocognitive Health, to characterize long-term forgetting in older adults and also to examine its association with early tau burden in Alzheimer's disease-related regions. So our sample consisted of 90 cognitively unimpaired older adults with amyloid and tau PET available. These individuals completed a face name associative memory exam assessment for 7 days in a row at home on a personal device. About a week later, they were asked to recall the faces and names that they'd learned the previous week. So initial learning was quantified using a multi-day learning curve metric, and we operationalized long-term forgetting as the number of correctly recalled face name pairs after 1 week divided by a participant's maximum performance during the initial learning phase. Moving over here, so the sample had a mean age of 75.7, and they were primarily white, female, highly educated individuals. 17.8% of the sample was amyloid positive. So we use linear regression models to investigate how the rate of learning across 7 days is related to the ability to recall information 1 week later, and whether long-term forgetting relates to temporal tau deposition. We found that on average, participants retained about 89.5% of learned material after 1 week. We also found that greater long-term forgetting was associated with lower multi-day learning curve scores, as shown in the first figure right here, and associated with greater temporal tau deposition, as shown in the second figure. And so overall, here we showed that weaker initial learning and greater temporal tau burden were associated with accelerated long-term forgetting after 1 week. And we also highlighted the advantage of using a remote digital assessment, and that it allows us to deploy these kinds of paradigms where we can assess both learning and forgetting processes that are relevant in preclinical Alzheimer's disease. Thanks.
Thanks so much. Questions for Cassidy? Can get us started off again. I was curious if you could share like some more details about the branch assessment and what that looked like.
Yeah, I know it's kind of difficult to explain in just a short amount of time, but basically, as I mentioned, it's a digital assessment that's taken remotely. So participants can use any kind of personal device that they have, like a tablet, smartphone, or computer. So that it's about 10 minutes a day, and they take it for 7 days in a row. So kind of in this paradigm, they'll take it for 7 days, and then about a week later, we kind of send them another assessment that's just a recall of faces and names that they had previously sort of learned over those 7 days. And we're able to kind of see how much they retain from based on how much they initially were able to learn in the first 7 days. So, yeah.
And did you find that most of the participants, like do you know what device most of them used? I know there are some like preconceptions about older adults not being a good population for digital health studies, but it seems there's research sort of debunking that, but maybe if you'd be interested in speaking to that a little bit as well.
Yeah, definitely. So we actually in the past have kind of seen sort of a 50-50 split of participants using smartphones versus computers. Yeah, definitely kind of debunks the myth that like older adults can't use smartphones or don't have them. We found a lot of people actually prefer to use a smartphone, as that might be kind of the device that they're used to, or they maybe defer to using just a smartphone as opposed to a computer. Sometimes, yeah, it's just a little more convenient for folks to do it on a smartphone. That being said, there are also about half the sample that chooses to do it on a computer because that is what they're more comfortable with. So we do kind of see a lot of both. But yeah, there's definitely more people that do it on a smartphone than maybe the average person would assume.
Room for a couple more questions if anyone has any curiosities. Okay, so next up we have Jenny presenting Navigating Professional Identities, exploring the impact of AI-mediated writing on locus of control.
It sounds like we can't hear you, sorry.
Oh, sorry, I think I'm muted. Can you see my screen?
Yeah.
Oh, perfect. Oh, I think myself is blocking the graph a little bit, but yeah. Hi everyone, my name is Jenny, really excited to be here. I'm a fourth year PhD student at Cornell in the Information Science department. And what I'm really interested in has been thinking about this idea of narrative and storytelling in the concept of empowering people to promote the sense of agency and sense of control. And this is kind of what motivates this line of research and this project, where we're interested to see when we're, for example, when people are writing their professional LinkedIn self-description, it's kind of like a process when they're reflecting on their professional journey. And with the emergence of adopting AI and different kind of machine system to help people to write it or to improve their writing, how might that has an effect on people's perceptions of self and their sense of agency? So to do that, we developed this writing interface, which embedded GPT-4 at the time, where people are able to write 5 to 7 sentence writing with a autocomplete system. So basically, our participant, after being recruited in the study, they first fill in some locus of control measurement as well as psychological empowerment measurement. And then they go into this writing task where they're either writing with the AI or without the AI, or different kinds of AI that are trying to elicit their sense of control, varying from external sense of control and internal sense of control. And what's interesting as a result of the study is that we found when writing with the AI system, employed participants are experiencing a sense of enhanced self-control, where unemployed participants potentially face a reduced sense of control. This can be seen in particular in the internal AI condition, when the AI is prompted to allow participants to write in a sense of first perspective and a sense of, oh, I'm the reason I am the major contributor to my success, and a very active in a very active tone. And we see that in this condition, participant who is unemployed tend to shift and decrease their locus of control into external, demonstrating that there's a need when we're designing and applying AI system, we need to think about how it has a consequence on different population, even with a good intention that they might shift their wants in like a positive perspective. So yeah, this is the pilot exploratory study that we have for this first project. I'm really interested in delve more into why and how these mechanism will work in my next steps. So I'm really excited to look for feedback and just to see if there's any questions or comments on where we're at. Thank you.
Thanks so much. Questions for Jenny?
You mentioned that so the two conditions were ones that emphasized external or internal control. Could you say a little bit more about how your AI system or your condition was doing that?
Yes, so we actually have 4 conditions. We have the non-AI condition where the participant were just writing their job profile. And then we also have 3 different AI conditions, which is the default AI. It's basically the status quo of what the AI system, like ChatGPT, will auto suggest based on the current prompt. And then we also have the external control AI, which is the one that's shifting towards sense of external control, locus of control, and the internal one. To do that, we actually build a writing interface where as the participant, it's kind of like Gmail. When you're writing something, the AI auto-complete your sentences with different suggestions. And participants have the option to render and shift the result, or they can just write. And then as they're writing, there will be new autocomplete suggestion coming up. And to do that and tinker, we actually just, what I did is I vary across that in the AI prompt. So for example, in the default AI prompt, it might be just that complete this sentence as this person is helping this person to write and complete their LinkedIn job description. With the external control, we kind of shifted that this is the goal to emphasis on external control, use a third person passive tool versus when we're in the internal control. And I said that, oh, the suggested test should be first person active tone with an emphasis on some of the previous literature has shown what are some features when people with a high sense of internal sense of control will be writing and their writing style. So we kind of tinkered a prompt to vary across different conditions.
Got it. Thank you. That's really helpful.
Thank you.
I have a question in the chat. How did you measure locus of control?
Yeah, that's a great question. We actually, the current one that I'm using, it's IE-4. I think it's a short scale. It's a 4-point. I think it's a 4-item scale in measuring locus control, where it has 2 focuses on the external and the 2 focus on the internal. I found this one is the best fit for the current study because it's kind of capture a range of sense of control, and but it also was not overwhelming to a participant because I still want to keep the study short. So this current task, I think the average completion time is around 8 minutes. And I'd like to, I think like my next step is I would like to have a more detailed metrics to measure, since we know that locus of control kind of has an effect and might impact people. So I might look into other metrics as well.
Hi, Jenny. Very interesting research.
Thank you.
So what do you think would be what's your hypothesis of why like employed users experience enhanced self-loss, it's like self-control, and then like unemployed users face those like reduced self-control.
Yeah, that's a great question. Thank you for the question. I think one thing that I was thinking about is that because writing like your previous job employment journey is kind of like I guess like because when the person is unemployed and they're writing and reflecting on their professional journey, there might evoke a sense of stress and negative emotions as they attribute that into something that they have not yet achieved yet. So one thing that we're thinking about, interested in exploring, is to look into if imposter syndrome might be a reason that could contribute to this result. But that was one of our hypotheses that could lead to what happened. The other thing we're thinking about is that it could be because as people are reflecting on a professional journey, the sense of very active tone in the internal AI kind of shift and highlighted their own contribution rather than external, like, oh, the reason why I was unemployed is because the job market is bad, things like that. And that kind of leads to a higher sense of like, oh, it's my own contribution of my current status quo. Therefore, it could lead to this like shift of external locus of control. I'm really interested to see if there are alternate hypotheses and any explanation, because this is something that also like I keep wonder after we found this in the results.
Awesome. Thank you so much, Jenny.
Thank you.
We next up have Tanvi presenting Practice EMA. Are we asking too much or too little? Exploring within-day differences in responses to repeated ecological momentary assessments of depression symptoms.
Hey, hi everyone. My full screen isn't working quite right, so hopefully you can see everything. Oops. I'm excited to be here today to talk about some of our team's work with EMA. Been spending a lot of time thinking about EMA, and one of the things that we know about it is that it can be useful for detecting real-time changes in mental health symptoms, and specifically in the case of depression, there are strong EMA predictors of elevated symptoms like elevated mood, which we've typically assessed across the span of 1 week in our own team's detection work. So as our team at Northwestern has been interested in expanding EMA beyond just looking at mood as a predictor into other kinds of cognitive and physical symptoms that can predict depression, we've also really been interested in seeing how we can detect depression not on the order of a week, but really even within the order of a given day. So as a part of that process, we actually wanted to see how different responses to EMA questions might differ within a given day, several hours from each other, to see if there's anything meaningful there. And so for about 700 adults who all had elevated depression symptoms, we compared their responses to these single question EMA assessments for mood, stress, fatigue, and distraction at one time point to one that was kind of immediately preceding after that, but several hours later. And what we found was that in about 40% of those cases, there's actually zero difference in how they're responding at the previous time point and the next time point. And in about additional 30 to 35% of the cases, there's only about a 1-point difference. And even beyond that, there's only about 15% of cases that have about a 2-point difference. So in total, like 90% of our responses that we're seeing for these EMA questions are falling within that 0 to 2 point difference. And this is obviously a very simplistic analysis in thinking about symptoms in this way, and we'd want to do a lot more sophisticated work. But like what it's starting to show is that there seems to be a lot of within-day stability in how people are responding to EMA questions. And so there's a really big trade-off that we might be thinking about with participant burden and having them answer all these questions multiple times a day versus actually wanting to be attentive to when those 10% of responses that are happening or falling outside of that 0 to 2 point range are happening, because that might be more indicative of significant changes in what we want to be paying attention to, and might also be kind of appropriate given that these are depression symptoms that might not need to change as frequently to be notable. And at the same time, I think there's some work to do with thinking about whether these scales are effectively measuring what to a participant is a meaningful change, because what we might be interpreting is not that significant with a 1 or 2 point difference might actually be making a big difference to participant lives. And so I think this is this work is kind of very early, as I said, but starting to think about how we balance what EMA demands of participants and what we might actually be getting in terms of our enhanced ability to predict, detect, and intervene in real time. So yeah, that's the crux of it, but excited to keep doing this work and to hear people's feedback on how they might be thinking about what is happening here, what we might be needing to be paying attention to in future, and how we continue. But thank you.
I have a question.
Absolutely.
This may be naive. How do you get 700 people to answer a survey?
That's a great question. So this is actually something that we did over a long period of time. It was like we did 3 different waves of data collection, and it happened around I want to say we started some of our waves before COVID, some of it like 2020 and 2021. So we like really had to diversify. But it was like very hands-off, completely remote study. And this is like the EMA is being delivered through a smartphone app. And so we didn't make it hard for participants to sign up. But there's a lot of energy and a lot of our resources were put towards recruitment, and we used a lot of like online forums and things like that to pull in people.
How do you thank you for that. How do you interpret missing data in this? Because like
That's a great question. Yeah.
like to my knowledge, I don't have depression, but like the second I feel off, I'm going to be like, I'm ignoring the survey.
Yeah, that's a great point. And that's one of the things also is like, we're trying to figure out if missingness itself is meaningful here, that you're more likely to respond. Like even if a person is choosing to respond one day and not respond the next, maybe that's an indication themselves of like, oh, they're more likely to respond when they're doing totally fine. And so a little bit more rigor about like how people's behavior is being impacted by these questions is important. And also in thinking about the burden, like maybe by reducing the number of questions, we're making it more likely that people will respond regardless of how they're feeling, because it's less of a lift. And so that way maybe we are capturing people's symptoms even when they are elevated. But that is a really great point. Yeah.
Thank you.
Yeah, absolutely. Any other questions? Well, thank you all for listening.
I have one quick question actually for the distracted component. Do you also, I guess, do you ask them what they're doing like
No, yeah, that's a great point. So as I'm thinking about like how do we change these things, one of the things I'm interested in is like how can we add context as a component, because what's unique about this, or what's particular about this study design is that it is like at fixed times throughout the day or like at random times, but it's not specifically tied to any contextual event or like life event that someone might be experiencing. And so what may be useful theoretically to get a big spread of their symptoms might not actually practically be useful because nothing's changing about those days. And so in addition to asking people how they're doing, we want to ask a little bit more about why. And I'll say that this is sort of part of a much bigger battery of assessments where we didn't just ask these 4 questions, but there was also passive sensing in this study. There's also like a whole bunch of other scales that they're doing. And so we kind of just were picking up the EMA questions, but there's ways to get that contextual information without having to ask them. So keeping the burden down, but having the value add of knowing what was informing how they were doing in that moment.
Totally. Yeah, I agree that context is important. Cool.
Absolutely.
Well, thanks. So yeah, last but not least, we have Sophia presenting rapid assessment of veteran and civilian user feedback to evaluate updates to PTSD coach.
Hi, everyone. My name is Sophia. I'm a research assistant at the VA. Can everyone see my screen? Okay, thanks. So I work on the mobile apps team, which is a team within the National Center for PTSD that actually puts out a lot of mental health apps geared toward veterans, but they're publicly available. So also civilians and anyone with access to Apple or Play Store can actually access them. So PTSD Coach is a publicly available app developed by the National Center for PTSD, and it's geared toward the self-management of PTSD symptoms. So it's not a treatment app, it's for self-management. Just want to be clear about that. So following a recent update, we had a in-app survey distributed to users on the 5th use of their app, or the fifth use of our app, and we had 167 respondents. And our results showed, as you can see in figure 3, that 80% of the respondents were actually reporting a PTSD diagnosis, which is really great because it highlights that PTSD coaches having the intended reach with its intended audience. And then our second result showed in figure 1 that the most common way users were learning about the app was through a healthcare provider. And then when compared to civilians, veterans were learning about the app, were twice as likely to learn about the app through a healthcare provider, which is really great because the VA has marketing and implementation procedures that run through VA healthcare system. So it's really getting to its target audience, but also the different programs within the VA are actually like being effective, which is really cool. So overall, this study basically showed that it's really important to collaborate with healthcare providers within the VA and outside the VA to target not only those veterans who have PTSD, but also civilians. So I think in the future, it'd be cool to kind of go outside VA healthcare system and kind of promote the app and its efficacy with civilian healthcare systems. Thanks.
Thank you so much.
Yeah.
Questions for Sophia? I guess I'm curious, any ideas you
Yeah.
have for like better promoting PTSD coach among civilians? And like, do you think
Yeah.
the reason it's not as popular among them is like maybe people think it's specifically for like veterans with PTSD?
Yeah, I think that is definitely one of the things. I think when people see that it's like a VA app, that they think, oh, I'm not a veteran or I'm not an active service member, so I can't use this app. It's also free and publicly available, so there's a lot of conflicting messaging, I think, around it. I think the other thing is that we also saw that civilians are more likely, though not significantly more likely, to learn about the app through like a web search or specifically like seeing it in the Google Play or Apple Store. So maybe having like more online marketing like through social media and because I think civilians have to go specifically look for it, whereas veterans are getting inundated with it within their like regular healthcare. So I think like kind of more marketing that kind of way would be more beneficial. Actually, Dr. Hines is here today. She's like one of the people that produced the app. And I think a lot of her like hope in the future is to like partner with a social media influencer who's talks a lot about PTSD and like see how that kind of changes the influx of people that we get using the app. I think it would also be helpful for veterans too who don't know about the app or think that like or are wary of app use and information, because that is also a big thing with veterans. Yeah.
And just adding on to Sophia's presentation, I want to give a plug for a presentation in a few minutes about how PTSD Coach was translated and adapted to help alleviate some of the suffering and the humanitarian crisis with the war in Ukraine. So there's plans to broaden its use. Thank you, Sophia, for this wonderful talk.
Which session is that talk in?
Good question. I think it's improving quality. It doesn't quite have an intuitive connection to the name.
I'll find it. Thank you.
It's Flash Talk 5.
Cool. Well, thank you so much, everyone, for these great presentations and thoughtful questions. Any final lingering questions for any of the presenters? Okay. We'll hope you all enjoy the rest of the conference and the start of the summer. And thanks again, everyone.